So, okay, I'll start the case. So we have now 98 participants. We expect around 100 this time. So, okay, this is part one of part two series. After taking this real case scenario, clinical case scenario, next week, after a few weeks, I'll be discussing theoretical aspects of clinical case scenario. So I'm Dr. Arun Maskey. I work as a professor of cardiology in NAMS and a senior consultant cardiologist in Syed Gangala National Heart Center. Good evening and welcome to you all in this clinical case-based discussion. So let's take the history of this lady. This is a 29-year-old lady who presented with dyspnea on exertion since she was 10 years old. So she's having these symptoms since 19 years. And since last 5 months, her symptoms worsened. And this worsening of symptoms occurred with onset of palpitations since last 5 months. So going back to history of this lady, she was, as per the history of the patient, which is quite reliable, she was apparently well 10 years back. And then she started experiencing dyspnea on exertions. This was NYHA class 1. It was insidious in onset, became gradually progressive. In the initial phase, it was relief with rest. At that period of time, she did not have any paroxysmal nocturnal dyspnea, PND, or orthopnea. But with the onset of palpitations since last 5 months, she started experiencing paroxysmal nocturnal dyspnea and orthopnea. And she says she can walk only 250 to 300 meters at a stretch. She also gives history of taking 3 weekly intramuscular injections. And she's taking few oral drugs with which she says she could not identify. She was prescribed the drugs by a doctor and she could take that medicines. And this was all started since last 5 months with the onset of palpitations. Before that 5 months, she never had any palpitations or history of syncope. There's no history of chronic cough, hemoptysis, fever, pedal edema, right upper quadrant pain. There's no history of polyarthralgia, arthritis, rash, involuntary movements, painful disease, or hospitalizations. There's no history of addiction or drug abuse. So in short, I've just taken a brief history for presentation. I'm not going into detail of all those histories. In summary, this is a 29-year-old lady. She had an insidious onset, gradually progressive dyspnea on exertions since the age of 10 years. So she was symptomatic since 19 years. Initially, it was 1 to 2 years, and this has rapidly progressed since 5 months. And this worsening of the symptoms occurred with onset of palpitations. Since last 5 months, she complains of orthopnea and paroxysmal nocturnal dyspnea, and now she is NYHA class 4. So, based on history, so how should we proceed with this history? So what are the possibilities in these patients, in this lady, 29-year-old lady? So any case, if you're given an exams, you'll have to think broadly based on history. Are we dealing with congenital heart disease, especially a cyanotic congenital heart disease, which is quite common in this part of the world? Most common is valvular heart disease. These valvular heart diseases are quite given in exams, so especially in MD exams. And third is, are we dealing with various cardiomyopathies? So these are the 3 important headings which you should consider when in this type of histories. So if you carefully look at the history, the disease has been slowly progressive. She becomes symptomatic in last 10, at the age of 10 years. Since last 19 years, her symptoms has become progressively increased from NYHA 1 to 2 to now 4. And Since last 5 months, with the onset of palpitations, her symptoms worsened markedly. So when we say palpitations, possibly we should think of arrhythmic events. Based on all these findings, based on history. So this history was since childhood. This has rapidly progressed with palpitations. So what are the possibilities we should think in this 29 years old lady? So we should think of three important causes. Are we dealing with a cyanotic congenital heart disease like atrial septal defect? This may have worsened by, since he's complaining of palpitation, whether this is worsened by atrial arrhythmias, or are we dealing with a rheumatic valvular lesions, now worsened by atrial fibrillation, because rheumatic valvular disease is quite common in this part of the world, and rheumatic heart disease patients are quite common and given in exams. Or are we dealing with any cardiomyopathies? It could be either infiltrative or dilated cardiomyopathies, or it could even be myocarditis. The important features in this cardiomyopathies, either they recover, or if it's some cardiomyopathies, then they will have a rapid downhill course. Based on her 19 years of history, this is very unlikely. And the most important thing is history. History taking is very, very important. She gives history that she's taking intramuscular injection 3 weekly. There's only one condition where you take intramuscular injection 3 weekly. So this, based on her history, we should think of rheumatic heart disease, because in only rheumatic heart disease, we take intramuscular injection 3 weekly as a secondary prophylaxis of penicillins. Now, let's say if it's a rheumatic heart disease, then there can be two. Are we dealing with the stenotic lesions, or are we dealing with the Riggerstein lesions? The most important features of Riggerstein lesions are, they may be dyspnea, but palpitation is relatively early features. Most of these patients with Riggerstein lesions, they are either associated early with palpitations, or dyspnea and palpitation occurs early. In this 29 years old lady, she had shortness of breath on exertion since 19 years at the age of 10 years, and palpitation occurred at the last 5 months only. So based on the history, so mitral regurgitation and aortic regurgitations may be a possibility, but this is less likely. Based on her history, this is a prolonged shortness of breath. This is slowly progressive. In the last 5 months, there's some palpitations, and this palpitations has worsened her problem. So the likely diagnosis in these patients is mitral stenosis with atrial fibrillation would be a likely diagnosis, which we will have to reconfirm with the examination. So this is how we should approach a patient based on history if we are dealing with any patients with valvular or cardiomyopathy or congenital heart disease. So let's go to cardiovascular examinations. She is thinly built, poorly nourished lady with a BMI just of 14. The pulse is 92 beats per minute, irregular, variable in volume. There's no radiofemoral delay. All peripheral pulsations are present. And there was a pulse deficit of 10 beats per minute. Her blood pressure was 122 by 80 beats per minute. JBP was raised 8 centimeter above angle of Lewis. There's no A wave, and there's a presence of CV waves. We all know that JBP 4 centimeter above sternal angle of Lewis is a raised JBP. There was no pedal edema. First heart sound is normal. S2 is normal split. There's a loud P2. There's an opening snap. Precordial bulge was present. The apical impulse was palpated in the left fifth intercostal space, just medial to mid-clavicle line. The apex was localized, ill-sustained. There was a systolic thrill present at apex, and left parasternal heave, grade 2 by 3 was present. So on auscultation of this lady, there was high-pitched blowing, pansystolic murmur, grade 4/6 in apical area, heard with the diaphragm of the stethoscope in left lateral position, breath held in expiration, and this murmur was radiated towards the left axilla. There's also low-pitched rumbling mid-diastolic murmur in the apical area, best heard in left lateral position with the bell of the stethoscope and breath held in expirations. There's also grade 3/6 pansystolic murmur in left lower external area, which increases in inspirations. Examination of the systems were unremarkable. Liver and spleen were not palpable. There was no abdominal tenderness. Optic fundus was normal. So now let's see from our examinations, what are the features of this examination finding in this lady? Since this lady has irregular pulse, so the cause is atrial fibrillations. The JPP in this lady was raised as the patient has atrial fibrillation, A wave was absent, and the presence of, there was a prominent CV waves. So the diagnosis from JPP is tricuspid regurgitations. There was grade 4/6 pansystolic murmur in the apical area radiating towards the axilla. So the diagnosis is mitral regurgitations. There is also mid-diastolic low-pitched rumbling murmur in the apical area. So the likely diagnosis in this patient is mitral stenosis. There's a pansystolic murmur in the left lower sternal border, which increases during inspiration. This is a murmur of tricuspid regurgitations. The apex pit is in the left fit intercostal space, just medial to left mid-clavicle line. It was localized, ill-sustained. So since this apex pit is just medial to mid-clavicular line, this indicates that this patient has no cardiomegaly, because anything which goes lateral to mid-clavicle line, we call it cardiomegaly. And if it's just medial to mid-clavicle line, so there's no cardiomegaly. The first heart sound is normal. Second sound is normal, is split. This is a feature of mitral regurgitations. So loud P2 is a sign of pulmonary arterial hypertension. This patient has opening snap. So this is likely due to mitral stenosis. Since he has grade 2/3 left parasternal hip, this could be either right ventricular hypertrophy or left ventricular enlargement, or it could be both. And the most important is he's on regularly on 3 weekly intramuscular injections. So this is a case of rheumatic heart disease. So if you carefully examine the patient and analyze all those examination findings, then we can come to a conclusion of a provisional diagnosis. This is rheumatic heart disease. And I would call this as a CVMS. I will be describing why CVMS. There's a moderate mitral regurgitations, moderate tricuspid regurgitations, atrial fibrillation. This patient is in NYHA class 4, moderate pulmonary arterial hypertension, severe pulmonary venous hypertension because of orthopnea and PND, the congestive heart failure, and no evidence of infective endocarditis or acute rheumatic fever. So these are the salient features of examination finding. Based on this, we can easily say this is a provisional diagnosis. Now, so I would be interacting after my sessions. If you have any questions, you can unmute yourself and ask questions, as this is a webinar, so I will not be interacting in each and every cases after presentation for the sake of the time. Now, let's say why this patient is NYHA class 4. When we say NYHA, New York Heart Association NYHA, so if there's a limitation of ordinary activities, it's a 2. If no limitation of ordinary activity, we call 1. It's marked limitation of ordinary activity, then we call it 3. And if it's unable to carry any physical activity or at rest, then we call it NYSA, New York Heart Association 4. So this patient has marked limitation of activities with orthopnea and PND, so we said it NYHA 4. So this patient has absent A wave because of atrial fibrillation. Remember that if the patient has atrial fibrillations, then A wave is absent and you will not get S4 because this S4 is due to atrial kick. A wave is atrial kick, so we will not get any A wave in atrial fibrillation. So raised JBP is a sign of tricuspid regurgitations in this patient. And the apex beat is just lateral to mid-clavicle line. Apex beat is defined as lowest and outermost point of cardiac pulsations. It's in the left fifth intercostal space. And the important is if the apex beat just shifted laterally in the same space, then this is due to right ventricular hypertrophy. If the apex beat is downward and outwards, this is due to left ventricular hypertrophy. We all know that apex beat is formed only by left ventricle. So if it's downwards and outward, this is an indication of left ventricular hypertrophy. And if it's just lateral in same space, it's a right ventricular hypertrophy. And another important finding is if you are examining the patients with the fingertips, you feel the apical impulse. Base of the fingers, you feel the thrills. And the base of the hands, you see the hips. So this is apical impulse, you feel in the fingertips. For thrills, you have to use base of the hands. And for the hips, you have to use the base of the hands. And this patient has grade 2/3 left parietal heave. So heave is either due to right ventricular hypertrophy or left atrial enlargement. And it should be palpated by ulnar aspects of the hands. There are 3 grades. We said this is grade 2. If the patients are just lift, it's visible, not palpable, then the grade 1. In this case, this was visible, palpable, and lift can be obliterated. So it was a grade 2. If it cannot be obliterated, then it could be grade 3. But in this patient, the lifting was visible, palpable, and the lift could be obliterated. So this is a grade 2, and you should always use base of the hand to palpate the hips. And the apex beat, if it's a tapping, would be in the mitral stenosis. If it's a volume overload conditions like MR, AR, it would be forceful and ill-sustained. In case of aortic stenosis and pressure overload condition, it will be forceful and sustained. And especially in patients with hypertrophic obstructive cardiomyopathy, you will have a double apical impulse. And in a dyskinetic apex, you'll get an uncoordinated apex beat. This patient does not have any tachyphyx or hyperdynamic apex. So this is a mixed case of mitral stenosis and mitral regurgitations. And this lady also has an opening snap. Any patient with opening snap, you should always consider mitral stenosis. The uncommon causes of opening snaps are volume overload condition like severe MR, VSD, and PDA. The importance of opening snap indicates that mitral valve is pliable. If it's a calcified, then you'll not get opening snap. So if you hear opening snap, then we can simply say this is valve is mobile, it's not calcified. So this is a very important finding in patients with mitral stenosis, because mitral stenosis patients, the treatment of choice currently is PTMC, PTMC. So opening snap is very, very important. So if we have opening snap, then we say this valve is pliable. So in exams, the exams are very fond of asking these questions. How do you differentiate opening snap from S3? So we all know that S3 is low pitch sound. If it's a low pitch sound, then it should be auscultated with the bell of the stethoscope. There are 3 conditions where you use bell of the stethoscope to auscultate. One, S3, S4, and mid-diastolic murmur of mitral stenosis. And S3 is heard in the apex. Whereas the opening snap is a high-pitched sound. It's heard in apex and between the lower left sternum area in between there. And since it's high-pitched sound, we should auscultate it with the diaphragm. And the most important differentiation between S3 and opening snap is if we ask the patient to stand, the A2 and OS interval will widen on standing, whereas this S3 will disappear. So this is most important findings. So opening snap is high-pitched sound, associated mitral stenosis. S3 is a low pace where we should use a bell. And grading of murmurs. This lady has a grade 4/6. So if you grade murmur, 1 is faint, soft, moderate, loud, and grade 4 is associated with thrill. In systolic murmur, we say grade 4/6, whereas in diastolic murmur, we have just 4 grades. Any murmur associated with thrill is grade 4. If it's a diastolic, it's grade 4/4. If it's a systolic, it's grade 4/6. And this patient has 2 pansystolic murmur. When you say pansystolic murmur, there are only 3 differential diagnoses. Either it could be mitral regurgitation, either it could be tricuspid or ventricular septal defect. So this patient has apical area pansystolic murmur, which radiates towards the axilla with the thrill. So that is a mitral regurgitation murmur. There's another murmur of pansystolic murmur in the left lower sternal area, which increases with inspiration. So this is a tricuspid regurgitation. Remember, if you say pansystolic murmur, there are only 3 differential diagnoses. And this lady also has a rumbling low pitch mid diastolic murmur. This is a classical of mitral stenosis. But there are few other conditions where we can also get this mid diastolic murmur, but this mid diastolic murmur in other cases are very soft. Like if the patient has a volume overloaded condition like severe MR, VSD, and PTA. If you get mid diastolic murmur in severe MR, in a patient with mitral regurgitation, this indicates severe MR. And other conditions like Austin Flynn murmur of severe AR or Caricum's murmur of acute rheumatic carditis, also, you will get this mid diastolic murmur. So mid diastolic murmur, classically mitral stenosis, but other conditions which are less common like volume overload conditions or AR or acute rheumatic fever, carditis causing Caricum's murmur. So these are the questions which are frequently asked in exams. Another is we had a pansystolic murmur in the left lower sternal area, which increases during inspiration. We all know that the murmur of the right-sided, they increase during inspirations, and murmur in the left-sided increases during expiration. So we'll also have to use whether this increases on inspiration or expiration. In this case, the apical murmur increases during expiration, whereas the left lower area increase in inspiration and apical murmur increase during expirations. In this case, the S1 was normal, but S2 was normally split. What we are expecting to get is in mitral stenosis, first start sound is loud, but in mitral regurgitation, first start sound is soft and absent. So we'll have to remember this S1 murmur is normal. So despite getting these patients with severe MS and MR, so because of this mixed pictures, we are not getting a very loud murmur or soft murmur, and the impression we are getting in this patient is normal first start sound. So let's, this patient also has loud P2, which indicates pulmonary arterial hypertension. For simple classification, there are 5 classifications now. If it's arterial pulmonary hypertension classification, if it's arterial, it's 1. Left heart disease is 2. Lungs is 3. If it's thromboembolism is 4. And if unknown cause or multifactor is 5. So this patient has pulmonary arterial hypertension 1, type 1, and venous hypertension type 2 in this patient. So we call pulmonary venous hypertensions. And this patient was doing very good. Why this patient deteriorated in the last 5 months is because of new onset of atrial fibrillations. The other conditions are in endocarditis, pregnancy, anemia, sepsis, or any cause which increases heart rate would deteriorate this patient. So this patient in the last 5 months had new onset atrial fibrillation, and that deteriorated this patient. Sometimes this patient with mitral stenosis would improve. The condition where they improve if the patient develops organic tricuspid stenosis or precapillary stenosis secondary to pulmonary arterial hypertension, then it's a protective mechanism and the symptoms will increase, will improve. So another important question which is asked in exam is if you have a mixed mitral valvular disease, mitral stenosis or mitral regurgitation, which is the dominant lesions. Important thing is we have to find out if there is a cardiomegaly, apex bit is shifted downwards and outwards, then there's a left ventricular hypertrophy or dilatation. So this indicates this patient has mitral regurgitations. If his apex beat is not left ventricle is not dilated, then the likely is mitral stenosis. The most important thing is third heart sound. Third heart sound indicates volume overload in mitral regurgitation. And if a mixed vulvar mitral stenosis and mitral regurgitation, if you get third heart sound, that indicates severe mitral regurgitations. Remember that in mitral stenosis, you will never get third heart sound. So please remember, no S3 in third heart sound, S3 in mitral stenosis. S3 is a indications of severe MR. And if LV is dilated, then that indicates the severe MR. This is a PET exam questions. So what other conditions would mimic mitral stenosis? So simple to remember. If there's any obstruction in between LA and LV, like vegetation, endocarditis, or high flow like VSD, PDA, then you get a mid-diastolic murmur, which I've already described. The other PET questions which are asked in exam is, what are the signs of severity of mitral regurgitation? Since we're dealing with these patients, our patient is a mitral regurgitation. So if you find the apex beat is shifted downwards and outwards, one. Another is third heart sound. If you get mid-diastolic murmur in apical area. So these three are classical signs of severity of mitral regurgitation. You might get other sounds. So shifted apex beat, S3, and mid-diastolic murmur in apical area is sign of severe mitral regurgitations. Another important questions for exam is, what are the signs of severity of mitral stenosis? There are two important signs. We all know that when we describe mitral stenosis, we say loud facet sound, opening snap, low-pitched rumbling mid-diastolic murmur in apical area, left lateral position, breath holding expiration with the bell of the stethoscope. This is a classical finding, and with presystolic accentuation if the patient is sinus rhythm. So remember these pictures. This is second heart sound. This is opening snap. Mild mitral stenosis, normal gap between second heart sound and opening snap, and duration of murmur is shorter. As the mitral stenosis becomes more severe, the duration between second hearts and opening snap becomes shorter, and the length of mid-diastolic rumbling murmur would be loud. So the two classical signs of severe mitral stenosis is shortened distance between second heart sound and opening snap, and longer mid-diastolic rumbling murmur. So remember, these are two important features of severe mitral stenosis. And this patient had elevated JBP. So what are the signs of severity of tricuspid regurgitation? Large V waves, right ventricular heave, pansystolic murmur, increases in inspiration, it becomes short. It is longer and harsher, and features of right heart failure like pulsatile lever, ascites, and peripheral edema. So if you get this, then we can clinically say this patient has severe tricuspid regurgitations. And remember, this sign is also very important. If there's a wide splitting of second heart sound, this is likely cause of severe mitral regurgitation is likely due to rheumatic origin. So this patient had wide splitting of second heart sound, so likely cause is rheumatic. So this is what about our history and examination. I try to correlate findings and the reasons why we get all those findings. At the end of my presentation, I would be interacting. So in the interest of time, I will not be discussing now. So at the end, please ask me questions. So we have taken history and we have correlated why this could occur. So now let's do investigations. We do just basic baseline investigations were all normal. So I'll not be going into those laboratory parameters. So I'll just be discussing ECG, X-ray, and echo. So this patient had irregular pulse. So this is a no P waves, heartbeats are irregular, axis is normal. So this is a case of AF with heart rate around 90. So this is a case of AF with controlled ventricular rate. And why I was saying is this patient does not have left ventricular hypertrophy, because this is a mixed valvular disease, mitral stenosis and mitral regurgitations. So from the ECG, there is no left ventricular hypertrophy, meaning that sigma MR is not significant. So how do you classify recently atrial fibrillations? So it could be first diagnosed, paroxysmal AF up to 7 days, up to 1 year is persistent AF, more than 1 year, either it could be long-standing or permanent. The difference of long-standing and permanent is in long-standing cases, we can change that AF to rhythm control strategy, but if it's a permanent AF, we cannot change that to rhythm, we'll have to control rate. In this case, this is a case of permanent atrial fibrillations. And this is an X-ray of same lady. Here you can see double border. The right ventricle is RV types. We can see some upper lobe diversion, and the pulmonary hypertension are not very clear in these pictures. So biatrial enlargement, pulmonary venous hypertension, and some left ventricular dilatation is not very significant. So RV type of X. So how do you say this is pulmonary venous hypertension? So simple to remember, if this patient has upper lobe diversion, 1, if the Curly's B lines are there, then it's 2. And if it's a frank pulmonary edema or bad wings, this is class 3. So the earliest, remember the earliest sign in patients with X-ray of mitral stenosis is cephalization of vessels. Normally, the vessels in base of the lungs are more than apical area, but if there's a cephalization, so mitral stenosis, the vessels are more in upper lobe. And this, we say this patient has some degree of pulmonary hypertension. Classical pulmonary hypertension would be dilated MPA, and right lobar artery would be enlarged, 15 mm in female and 16 mm in male, and there would be some right chamber dilatations. And most of these patients with pulmonary hypertension will present with exertional dyspnea, fatigue, chest pain, exertional syncope. And the classical findings would be because of pulmonary hypertension, loud P2, right ventricular leaf, jugular venous distensions, and right heart failures. And if the severe pulmonary hypertensions, then you'll get a tricuspid regurgitation and pulmonary regurgitation. So these are the classical symptoms and signs of pulmonary hypertension. Now let's see the echo finding in patients. The mitral valve area was 0.98, dilated LA, and there was a moderate aortic regurgitations. So this is a moderate aortic regurgitation, at least. MBA was 0.98, so very severe mitral stenosis. And dilated LA, LV size is normal, and ejection fraction is normal. And tricuspid regurgitations, there was a moderate tricuspid regurgitation with moderate pulmonary arterial hypertensions. So this is a finding in patients. So based on our history, examination, echo. So the final diagnosis is rheumatic heart disease, severe mitral stenosis, valve area of 0.98 centimeter square, moderate mitral regurgitation, moderate tricuspid regurgitation, severe pulmonary venous hypertension because of orthopnea and PND, severe pulmonary arterial hypertension. This patient has AF with controlled ventricular rate. In New York Heart Association class 4, no rheumatic activity, infective endocarditis, or thromboembolism. So if you are appearing in exams, so if you're getting any rheumatic heart disease, valvular heart disease, if it's a rheumatic origin, try to say etiology of patient and give a diagnosis. In a valvular heart disease, if it's a rheumatic, you should not forget to tell, if possible, about venous hypertension, arterial hypertension, the rhythm is sinus or AF, and you should always say rheumatic activity, infective endocarditis, or thromboembolisms. So how do you treat these patients? Since this patient is symptomatic, so you should have initial medical management with diuretics, beta blocker, digoxin, and Cs29, CNS penicillin prophylaxis, and anticoagulation with warfarin. So remember that digoxin will control resting heart rate. To control the heart rate during exertion, we'll have to add some degree of a low dose of beta blockers. And CNS penicillin prophylaxis, at least for 40 years, secondary prophylaxis for penicillin for 40 years, and maybe for lifelong. And as this patient is rheumatic severe MS, she needs anticoagulation with warfarin. And the treatment of choice in this patient is mitral valve replacement with tricuspid valve repairs. So there are two types of anticoagulations. One is a traditional, which is warfarin, and newer oral anticoagulation. There are two groups of newer oral anticoagulation. Dabigatran is a direct thrombin inhibitors, factor Xa inhibitors like rivaroxaban, apixaban, and indoxaban. So remember that there's no role of NOACs in patients with rheumatic severe mitral stenosis and prosthetic valves. You should not use NOACs. In these two conditions, indication is always warfarin. So this patient has severe MS, rheumatic severe MS, and atrial fibrillation, so she should be used on warfarin. So that's the reason why I said anticoagulation with warfarin. And is she fit for a PTMC? Yes. If in a case of symptomatic severe MS, less than 1/5, if valve suitables, because opening snap was there, so this valve was suitable. But the contraindication is left atrial thrombus and moderate or severe MR. So since this lady has moderate MR, so she is contraindicated for PTMC. So this is a mixed valve disease. And this patient will require mitral valve replacement with metallic prosthetic valves. Reason is she has atrial fibrillation. The advantage of a biprosthetic valve is patient will not require oral anticoagulation after 3 months. But she is a 29 years old young lady. In a country like ours, doing second operation in a poor lady is difficult. The advantage of biprosthetic valves are they do not require anticoagulation, but they do not last longer, up to 10 years. If you use metallic valve, they last longer. So the duration of valve is longer with metallic valve. But since this lady has atrial fibrillation, so there's no question of using biprosthetic valve because we have to use anticoagulation. And again, I want to repeat, there are two conditions where NOAC should not be used. One is rheumatic mitral stenosis with AF and metallic valves, prosthetic valves. So this patient will be requiring mitral valve replacement with metallic prosthetic valves. So she should be on oral anticoagulation. And since this patient has moderate moderate TR, so you'll require tricuspid valve annuloplasty with tricuspid repairs. So the indications for mitral valve replacement in severe MR is either the patient is symptomatic, or if they're asymptomatic, we all know that if his end systolic dimension is 40 or ejection fraction is less than 60%. So this patient has annulus of around 45. So if the patient has CVTR or if annulus is more than 40, then this patient requires tricuspid valve repair as per the guidelines. So it's a 45. So that's why they require mitral valve replacement with metallic valve and tricuspid valve repairs. So the question is, do patients with valvular heart disease, they require IE prophylaxis? As per the current guidelines, there are only 4 conditions where they required IE prophylaxis. If the patient is prosthetic valves, if the patient has previous infective endocarditis, if the patient has congenital heart disease, like unrepaired cyanotic congenital heart disease only, either with the palliative stents or conduit, or if unrepaired. If the patient is repaired congenital heart disease with a device or surgery, and then they required for 6 months. If the patient has congenital heart disease repaired, if there's vestibular defect, then they should require IE prophylaxis, and 4th is cardiac transplant. So current recommendation is in patients with valvular heart disease, you do not require any IE prophylaxis as per the guidelines. So thank you very much, and I hope you enjoyed my lectures. And if you have any comments or feedback, I would be very happy. You can call, you can send message, or you can call me and give your comment or feedback. Thank you very much. So I'm happy that we have now 116 participants joining this session. So now I'll be happy to take questions if you have any. If anybody has questions, please unmute yourself, and you can please identify yourself, because most of the residency I do not know. So identify yourself and Ox, any questions or if you have any comments, I'd be very happy to answer those. Thank you very much.
So there is a question in the chat box, sir.
Chat box. So person can unmute yourself and, okay. See, primary and secondary MR is a dilatation from any cause, like if you have a dilated cardiomyopathy, or if any condition that dilates, like so you can identify based on your morphology of those patients. If you have a rheumatic heart disease patients, the mitral valve would be thickened, mobility is reduced. So we can identify those based on clinical history and echo findings. We definitely can identify all those. Yes. So this is open for, please unmute yourself and ask direct questions. That would be great. So either this lecture was very useful or maybe it's too tough and nobody understood anything what I said, or everything is quite clear. Namaste. Okay.
Sir, Dharmendra sir, I am intermedicine.
Okay, sure.
Sir, मेरो एउटा question sir, यो pulmonary venous hypertension छ नि sir, arterial hypertension र venous hypertension, यसलाई हिस्ट्रीबाट कसरी severity गर्ने sir?
Well, let's see. If you have a patient with dyspnea, shortness of breath, you should think of pulmonary venous hypertension. And if you have a patient with orthopnea and PND, now you can see simply say from the history it's a pulmonary venous hypertension, severe pulmonary venous hypertension. To say it's pulmonary arterial hypertension, there's a P2, parasternal leaf. These are all features. So if you have orthopnea and PND, dyspnea is a sign of pulmonary venous hypertension. So orthopnea, PND, if you have straightforward, say it's a severe pulmonary venous hypertension. So that's what you can identify. And radiological, I've said 1, 2, and 3, which is from the upper lobe diversion, Corliss B-line, and pulmedema. So that is difficult because you will not get X-ray. So orthopnea and PNDs are very important.
Thank you, sir. भनेपछि सर यो सिभियर भनेर मात्रै चाहिँ भन्न सकियो हैन सर हिस्ट्रीबाट?
If the patient has shortness of breath and exertion 2 or 3, then you can say moderate. If a patient has orthopnea and PND, you can straightforward say it's a severe pulmonary venous hypertension.
Okay, sir. Thank you, sir.
There is another question in chat box.
This patient has TR, left parasternal. Still, there was no shift of apex width. So can only dilated LA explain this patient needs? Because it seems very unlikely to have TR and no RBH. Can you see, this patient is a case of mixed valvular heart disease. And if you look at this patient's findings, severe mitral stenosis and moderate MR. So possibly this, and there's some degree of tricuspid regurgitation. There's a raised JBP, but no features of peripheral edema or tender hepatomegaly. So based on that, we can say this patient has moderate TR. And the left parasternal heave was grade 2. In the context of severe MS, moderate MR, the likely diagnosis would be dilated LA is a reasonable answer to say this, this is a case of not right ventricular hypertrophy, but it's because of dilated LA. If it's a significant right ventricular dilatation, then you would also get the epigastric pulsations. So clinically and from echo also, we could say this is a dilated LA. It's true.
So there is another question in the chat box again.
See, valvular heart disease and dilated cardiomyopathy from history. So if you have a valvular heart disease and dilated cardiomyopathy, you can differentiate. The difference of dilated cardiomyopathy from valvular heart disease is dilated cardiomyopathy, any valvular heart disease like MR, AR are secondary to dilatation. So they are secondary. And the most important is if you have a patient with dilated cardiomyopathy, the prognosis of this patient would be rapid downhill course. So they would deteriorate within 5 years and they will have a severe heart failure in these patients. And for rheumatic is a valvular heart disease, the course of disease is slow and progressive. So dilated cardiomyopathy from history. If a short history, rapid deterioration, then think of dilated cardiomyopathy. You can definitely find out history. I've already said in history, if it's a cardiomyopathy cases, either they recover or they go the rapid downhill course. So from the short history, if it deteriorates rapidly, then you should think of dilated cardiomyopathy in a patient presenting with heart failure. Yeah, you can identify. Thank you. I do not see any questions. Is that all?
Excuse me, sir. Sir,
Yes.
can you clarify your improvement of dyspnea in mitral stenosis in one of your slide?
Yeah. So what exactly happens is if once the patient has pulmonary hypertension,
Yes.
and if the patient develops tricuspid stenosis, secondary to congestive heart failure, because these are protective mechanisms. What exactly happens is, see, from LA to LV, the blood is going. At first, there's a pulmonary venous hypertension. There are two parts.
Yes.
Artery is precapillary, and after the lungs is postcapillary or postcapillary. So if the patient has a pulmonary hypertension, then these are protective mechanisms, and these patients show relatively improvement. They are not actually worsening, but some relative improvement is there if the patient has pulmonary hypertension or precapillary hypertension. So these are the protective mechanism which protects them, because this will prevent the congestive heart failure in early stage. Once they become severe, then they go into rapid downhill course. So these are the protective mechanisms.
Sir, namaste.
Namaste.
Sir, history-wise, left-sided regression lesions like MR, AR, मध्ये isolated MR अथवा AR history-wise चाहिँ हामीले कसरी सर छुटाउने र कम्बिनेसन सो AR र MR सँगै आयो भने चाहिँ history-wise कसरी हामीले differentiate गर्ने सर त्यो यसो भनिदिनुहोस् है.
So if a patient has regurgitation lesions, the predominant symptoms would be shortness of breath, but they would occur with palpitations. That's one important thing. So in this case, shortness of breath was there and late stage of palpitation, which is a feature of stenotic lesions. So if the patient has shortness of breath or palpitation initial features, then we could think of regurgitation lesion. So difference of mitral and aortic regurgitation is aortic regurgitations will have symptoms mostly at night, because once the patient is in the resting state, the stroke volumes out, the palpitation occurring at night, night sweats, these are more features of aortic regurgitations. So you'll have to take careful history of these patients of palpitations. And predominant symptoms in aortic regurgitation starts with palpitation, whereas in mitral regurgitations, the shortness of breath and palpitation would be simultaneously. So this is how you have to identify aortic regurgitation from history. And another is this patient will have, in patients with severe aortic regression, some degree of peripheral signs, head nodding, and most troublesome first presentation of aortic regression is palpitations. And then later stage, they'll have shortness of breath. But in mitral regression, predominant is shortness of breath along with palpitation. So this is how you can identify one. And second is night symptoms are more common in patients with aortic regression, night sweating, night palpitation, and they feel everything in the night because it's a quiet environment. And when the patient turns left side, they feel more. So this is how you find from the history. You see, histories are suggestive. So based on history, you'll have to make a diagnosis in this way.
Thank you, sir.
There is another question in chat box.
So palpitation is a very important history. So if you get any patients with palpitations, so what is palpitation? It's awareness of abnormal heartbeats. No? So if you get a palpitation in a patient with complaints of palpitations, then the best thing is you should ask patient to use your hand and ask the patient to tap in the table. So how you get, is it sudden onset, sudden offset? If it's a sudden onset, sudden offset is likely to be arrhythmia. If it comes slowly, then palpitation and goes gradually is a case of sinus tachycardia. And you should ask patient to tap on the table and say, okay, you have a palpitation, see how it comes, this, or this, and this. So that's how you can, from the history, you can say this is whether this is a tachycardia-induced palpitation or arrhythmic palpitation. And the other is whether these palpitations are associated with symptoms like dizziness, lightheadedness, syncope, pre-syncope. These are also very important. And if these patients are associated with neurological symptoms, if the patient is arrhythmogenic atrial fibrillations, the chances of having neurological manifestation is 3 to 5 times. So you'll have to tell neurological symptoms also. Important is onset and offset. Sudden onset, sudden offset, arrhythmia. Gradual onset, gradual termination, likely to be sinus tachycardia, and ask the patient to tap in the table. So that's his important history we should tell in exam while describing palpitations. So anyone from NAM? NAM's not asking any questions? So I think no more questions or comments. Now I request this program was possible because of Dipesh Pradhan from Asian Pharmaceuticals. I'd like to thank him. So I will ask him to speak few words.
Thank you very much, sir. Thank you very much, Arun, sir. We'd like to thank all the doctors. Oh, there's a call right now at the same time. We'd like to. So
we had around how many? 170
yeah, today
participants?
we have almost 125 participants, sir.
Okay, good.
Almost 125, except Pachishana. So right now still we are 101 right now. So again, sir, I'd like to thank you and all the doctors, and we are very much proud to be associated with this kind of academic program in the CME, or we can say class academic program. So in coming future also, we'd like to be associated with this kind of academic program, and we'd like to support each and every doctor or medical practitioner in their academic field. And so, sir, since last 23 years, we are in the market. Asian Pharmaceuticals is there, and so since last few months, we are with a specific cardiac product also with our division Cardiac, and we are here in the field with our new division. So we'll be there to see you, all the doctors, individually and to promote our products, sir. And we hope all of you will support us in our new division also, sir. Thank you once again. And so there's another request from from doctors that they would like to have the slides or video. So can we provide them?
Yeah, that's fine. I mean, I can provide them.
So सबैजना जसोहरू अब सरलाई कन्ट्याक्ट गर्नलाई या मलाई
Okay, ask them to contact me, so I'd be happy to
Yes,
share
sir.
with them.
यो प्रोग्राम रेकर्ड भइरहेछ अनि स्लाइड्सहरु पनि सरसँग छ.
Okay, sure.
So once again, thank you very much.
So thank you, Dipesh, for helping in this one. And thank you all participants. So I hope you all enjoy. So this is part one of which I try to explain how you should approach a patient with valvular heart disease. So this, I mean, the best option is bedside teaching. You cannot replace bedside teaching in any forum. I can give you lectures maybe 100 times, but until and unless you see patients, do a bedside examinations, you will not be learning too much. So, but even then, because this period of time, at least if you know theory, I hope you will enjoy, because see, there's one saying, eyes do not see what mind does not know. If you're given an X-ray, if you know your mind knows what is the finding, you will be able to explain. If your mind does not know, and then you'll say this is plain flame. So this is how, if you make a strong theory. So my principle is make your basics very strong. Whether it's an MBBS exam, whether it's an MD exam, whether it's DM exams, you'll be asked basic things. And if you know the basic things like which I have explained, so if you know that this basic things like mitral stenosis, no S3. Atrial fibrillation, no A waves in JVP, no S wave, S4. And other conditions which I have not explained here, like bail of the stethoscope, you'll see 3 sounds, S3, S4, and mid-diastolic mount. Dynamic auscultations are present in 2 conditions, mitral prolapse and hypertrophic obstructive cardiomyopathy. If you know these basic things, you'll not miss in exams. So these are the basic things which I've been trying to teach you all, and learn basics. Once your basics are strong, then you can correlate. Like in a patient's mitral stenosis, first start sound is loud. If the patient has severe mitral regurgitation, the first start sound is soft or absent. So if you are given a case of pure MS in sinus rhythm or mitral stenosis, you'll close your eyes and say this is loud first start sound. If you are given a severe MR, isolated severe MR, and if you want to say anything, thus you will close your eyes and say this first start sound is soft, whether you have heard that first start sound soft or no. So this is how you should approach. And this is the basic things which I was trying to tell to you all. Maybe if you have a interest, maybe I will, this is a webinar-based, case-based discussion. Maybe next time, if you want, I can give a theoretical lecture on how to approach a valvular heart disease. Thank you all participants. So 125 is a good number. And thank you, Dipesh, for supporting this program. And we have done a wonderful job. Thank you and good night to all. Thank you.
Thank you. Good night, all those. Good night.
Good night.
Please take care. Stay safe. Thank you.
Thank you, sir.
Thank you.